If you enjoy this content, please take a moment to rate and review it. Your feedback will greatly impact our ability to reach more people. Thank you.
Okay, welcome to Health Further. I have a guest host today, Emily Evans, a recurring expert on health policy. We have not much going on in health policy this week, so we'll have to make up.
It's so boring. I wish something interesting would happen.
Yeah, thanks for doing this. Marcus is somewhere at a conference. I think he's in South Florida.
Oh,
so,
lucky him. It's snowing in South Florida.
Yeah, so maybe not the best time to be down there. But thanks for doing this. Let's dig into the stories this week.
All right.
Okay, so we're going to start off with the economy and food prices. And Hedgeye has been all over this, really helped me understand it. But food prices have been significantly up over the last several months or years, really. So we're showing people that are listening and not watching. First of all, you should check us out on YouTube, but I'll describe it. So we have 6 food products here: sugar, coffee, potato chips, milk, bread, and ground beef.
Well, you shouldn't be eating potato chips, so don't worry about that one.
That's actually the one that is not spiking so much. Maybe people are cutting back on their potato chips. But the one that really caught my attention is sugar and coffee, just because they are up 80%, 70% over the last 5 years. Yeah. These are underlying commodities. I mean, certainly I buy sugar and coffee, but they also go into lots of other food products.
Right. Yeah. And sugar, you know, they're both fairly labor intensive, right?
Yeah.
Harvesting them, and that's the cost of people is what you're seeing there. But the price of goods is rising because everything else is rising, and this is what this is called inflation. This is called inflation, and the terrible thing about inflation is once it gets started, it's really hard to stop.
Yeah.
And that's the quandary the Fed is having, they raised interest rates and then misjudged things and lowered them too soon.
Yeah.
Which is exactly the same problem.
It's what they do every time, really.
Yeah. And most famously by Arthur Burns, because he was under a lot of pressure from Richard Nixon in the 1970s.
Right.
So this story is...
Well, luckily we have a president that won't apply any pressure this year, I'm sure.
Well, it's already started, and it's on the news today saying that he wants to... we need to cut interest rates. The thing that causes inflation...
Cutting interest rates would not reduce inflation.
It would not reduce inflation, but if you cut at the same time the significant amount of government spending that is actually... Inflation doesn't happen until some extraneous force comes in there and pushes up prices. And in our case, that was the Inflation Reduction Act, as well as some other things. And quite honestly, just some really crazy behavior at the Treasury Department.
Let me just pause for a second to make sure I'm understanding. Because the naming conventions in D.C. are hard for me to get my head around. So I think you just said the Inflation Reduction Act was a catalyst that caused inflation.
Absolutely. So there's this new thing in Washington. So you name it the thing that it's not.
Name it the opposite of what it is.
Like the American Recovery Act or the Inflation Reduction Act. Just name it the opposite of what it is, and you might fool.
Well, no one reads the rest of it. So if you get the title, then the rest of it doesn't matter.
Yeah. Well, you might fool about 10 or 15 people.
Yeah. So I think we're covering this every week. I think we're in this world of we are going to have higher than the Fed's target 2% inflation, almost certainly.
Yes.
For a long time.
Yeah.
And they have an option of cutting rates, which would spur certainly growth in financial assets almost immediately.
Right.
And then maybe it would filter through to the rest of the economy. But it would certainly not stop inflation. Or they can...
Unless...
let's go to... Unless Elon Musk and Vivek and Trump are able to actually cut $1 trillion or $2 trillion out of the government budget, which would be wonderful, because then we'd have kind of the Goldilocks where you start to cut the amount of spending, which helps with inflation, helps. There's less money floating around.
Right. Yeah.
But it also would mean government is one of the inputs into GDP.
Right.
So I think the math is if you cut $1 trillion out of the G in GDP, it's not likely that the economy will grow.
Well, you will have to make that up somewhere else. And how would you do that? You would lower interest rates. That's the coded, somewhat coded message. There's this thing that people believe, well, the Fed controls inflation, right? No, inflation is driven by fiscal behavior. This was true in the 1970s, and this was Richard Nixon's problem. Mm-hmm. You know, Paul Volcker had to basically drive the economy into a ditch. That's what he had to do.
In order to get control.
In order to get control of the situation. And at that point, you saw what? Deregulation, which started under Jimmy Carter and then continued under Ronald Reagan. And you had banking law changes. You had significant tax reductions. You had all of those things. So it all worked out well. But when you just say, oh, yeah, we're going to lower interest rates, yeah, of course, you're going to drive inflation up if you do that. Yeah. And the mistake that Jay Powell made when he did that 50 basis point cut
in September
was that the Fed was still borrowing short term. So you were pushing a bunch of liquidity into the
Treasury.
Right? Yeah, the Treasury. I'm sorry. The Treasury was borrowing short term. You're pushing a bunch of money, creating liquidity, false liquidity. At the same time, you're pouring money out of the Inflation Reduction Act into infrastructure projects, some of it non-productive, some of it like Green New Deal stuff that doesn't actually produce a result, some of it productive, but mostly you're pouring all this money, particularly into state and local governments, and that is inflationary. So yeah, he cut those rates, that's inflationary, but then you're adding all these inflationary things on top of it. And so what do you get? You get ground beef at $5.61 a pound.
Right.
Yes.
Yeah. And so the optimistic view is that Trump and Doge will be effective at cutting maybe not very important spending in the government, which we don't need and would be really beneficial. And then the Fed will have the latitude to cut rates, and it will be great for everyone.
That's the formula they're aiming for, and it's not crazy. That was Ronald Reagan's formula.
Yeah.
Okay. He had to withstand Paul Volcker's tightening, which he could do because it was early and he was a very popular president.
Yeah.
But then came all these fiscal long-term changes, which got the boat righted, if you will, and the economy takes off and is running pretty hot for quite a few years.
Yeah. And so let's jump into the next phase, and then we're going to come to policy in a minute, but we're going to start at first with the venture markets. Lindus Health raised $55 million to fix the broken clinical trials system. They have a product they call themselves Anti-CRO, which is Contract Research Organization. Basically, they're sort of bringing efficiency to the clinical trials markets, which I think there's a lot of opportunity for that.
Yeah, I think that's right.
And so there's also a lot of embedded difficulty to change in that space, but I'm excited about them working on it.
Well, as long as you have so much disruption going on in biotech and pharma right now, you open up pathways for people to innovate. Whereas 5 years ago, biotech was hot; it could do no wrong. Biopharma is up and rising and tons of dividend income. Why mess with it, right? So you start to mess with it when you see
now they have to find more effective ways to get new drugs to market.
Yeah.
So this could be good, I think. Then we have Eleos is an AI scribe specifically for behavioral health. So we've seen a lot of AI raises, and scribe was probably one of the first use cases. And they're making a bet that there's enough differences in behavioral health that it's worth it to have a dedicated tool.
Behavioral health versus physical health, right?
Right.
Okay.
Yeah. So this is a system that is ambiently listening to a counseling session, which I think has some privacy concerns.
Yeah, I would see clinicians as being kind of resistant to that.
Yes. But then it produces the clinician report automatically.
Right.
And the clinician, I think I read it earlier, instead of taking 20 minutes to document the session of an hour session, they can do it in 5 minutes. They need to look over and make sure the typos are not right and it did cover what they covered. But, it's typical. This is the ambient scribe market, in the clinic. it's listening during the patient encounter with the doc.
Right.
And so it's the same, but it feels a little different talking about mental health than physical health from a privacy point of view.
Yeah, well, there's a lot more subjectivity to behavioral health, because it's really somebody reporting how they feel and what they're thinking about, and the therapist trying to guide them, but it's a lot of subjectivity. There's no X-ray, right? There's no blood tests. There's no conversation about this piece of scientific data that I present to you and we discuss it. That's not, that doesn't happen. So it's the treatment itself is the conversation. So it's a little.
I don't know if this is a separate market. I think that the ambient scribe existing players would argue they could do this as well, but we'll see. I mean, Ellis
what I would think is the most interesting thing about this is what information is collected and what can be trained on that information. Is there a certain, and I think that there's going to be a real emerging, and there already is an emerging questioning of all of this therapy that's being delivered to children, in particular, children and adolescents, and not to be like too much like my mother, but there's a certain point at which you've crossed over, and it's you really, kid, you need to kind of buck up and move on, kind of thing. Which is not to diminish, real mental health issues. I'm just saying that there is an Abigail Shire, who writes often for the Wall Street Journal, has written a book called Bad Therapy, and that's this sort of over medicating, if you will, through therapy through young people who are naturally inclined to do what? To please others, and including therapists, and sometimes come up with some stuff that is fairly counterproductive. So there's this kind of questioning of that going on that is makes me wonder, and what I'd be interested in is what is when this, when you aggregate all the data it collects, what is it concluding? What is it? What conclusions can you draw? That's, to me, interesting.
That is pretty interesting. I don't know that is what they're thinking about right now, but all of this data is going to be available in a different way than it was previously. It used to be that the whether it's physical or mental health, the doctor did his or her thing, and then they wrote up the notes. And now we're collecting a lot more data. We're basically transcribing every physician encounter.
Yeah, and so we might learn a little bit about what the right kind of doctor
what are they doing?
is. Yeah, what's the best kind of doctor?
Okay, so Oshie Health raised $60 million to expand their virtual GI solution. This was led by Annie Lamont's company, Oak, HCFC, but a group of other investors, sort of a really strong list of investors. And it is a virtual sort of way to look at GI health.
GI health is one of the dark, dark corners of healthcare because it's, one, really complicated. Okay.
Yeah.
And two, everybody wants to be a cardiologist, a neurologist, or an oncologist. With few exceptions, very few people want to be GI docs. That's your colon and your bladder, and they don't want to. It's not as interesting, but
it's very complicated.
It's complicated, and it's really important.
Yeah.
And one of the tracking
and the gut biome. I mean, I think the gut biome really affects all your overall health.
It's yes, what you eat, and back to the mental health thing. What you eat has, and how healthy your gut is a really big part. And Chris Palmer at Harvard has done some of this research that is, I think, going to redefine behavioral health, and with it, gut health. So I could get really excited about that.
Yeah. So it's a sort of a wraparound model for virtual GI.
Yeah. They need all the help they can get.
Okay. And then we have Percipio. It is an RPM company, remote patient monitoring, which, we've invested in several. It's pretty commonly understood. If you have chronic disease, you take biometrics and monitor the patient's health. They're doing it with a cell phone only, and that's pretty interesting. I don't know how they're doing that. They're using AI to do that, whatever that means. So vision-based algorithms assess vitals and medication adherence. In order to qualify for reimbursement, you have to get 15 days of blood pressure, weight,
right, which is reduced.
Glucose.
Yeah.
How you get that with a vision, a phone camera looking at the patient, I'm not sure, but that's what they're doing.
Yeah, this is interesting for this reason, and all of the AI products, I would say that this is true, because so much advancement and innovation of AI has been held up by the adverse regulatory environment in the last 4 years. I think you're going to see there's a lot of pent up activity that needs to move forward, and so that's interesting to me for that reason.
I mean, if it is possible for my Android phone to know my weight every day, or my blood pressure, or my blood glucose levels, that would be great. I don't know that I've seen a device that can do that.
I have not either. No.
So,
or that a doctor would accept that information.
Yeah, well, yes, the doctor might not accept it, but the CMS won't pay for it unless it's
nobody,
an FDA approved
you can collect
device.
that information, but nobody wants to use it.
Right. Okay, then Redesign Health, which is a U.S. investor, partnered with Sanabil Investments to launch a venture studio in Saudi Arabia.
Okay.
So that's pretty interesting, where we are now exporting some of our medical expertise to Saudi Arabia, which is great.
Yeah, and Saudi Arabia, I think, announced that they're going to be making some significant investments in the U.S., which they had not been interested in doing for a very long time.
Yeah.
So that's pretty interesting.
Yeah, and Marcus is going to Saudi Arabia in late February, I think. So
we are opening an office there, I believe.
Oh, really? HHS opening an office there?
I believe so.
Is that so? You have an office in Nashville, D.C., and Connecticut.
Our offices are in Washington. And in Boston, Stamford, Connecticut, and we have one on the West Coast, which is mostly technology.
Oh, okay. So this would be your first international office.
I believe so, yeah.
Okay, and then this was a really interesting story. We're starting, I mean, this is still a VC adjacent kind of story because Trump and Larry Ellison and Miyasuchi's son.
Yeah.
And Sam Altman announced at the White House a $500 billion fund to invest in AI infrastructure.
Yes.
And it was really exciting in the moment, but then there's been several maybe less exciting things that have come out since.
Well, this is political theater. I hate to break anybody's heart.
Right.
But it's political theater. And it's political theater for a good purpose, okay? What Donald Trump is saying there, specifically to Barack Obama, his nemesis, okay, but to a lesser degree, Joseph Biden, what he's saying there is that whole thing you tried to do, controlling AI through your regulation, that...
Yeah, the Biden executive order that Obama was heavily involved in.
Yeah, which is weird to begin with, right? If you're the former president of the United States, I expect a few things of you. One, you're supposed to be really tired and need some time off. And two, you're supposed to go write books and give speeches and paint pictures. You know?
Yeah, like I think Clinton and Bush both have done a good job. They're around, but they're not involved in the same way.
It's a violation of norms going back to George Washington.
Right.
And however you may feel about the politics of Barack Obama, that's everybody's personal business, but there's no questioning it violated norms for a former president to sit down and write an executive order that was then produced over the signature of his successor or his former vice president. And Mark Andreessen is the one who talks about this best in, I believe, his podcast with Joe Rogan, where he says, we go to this meeting and, this is under the Biden administration. This is a year ago or 6 months ago. A year ago. And we go to this meeting and, basically the staff said, well, you don't need to worry about that AI thing. We got it covered. It's going to be Google and Apple and, I don't know who else but basically, 3 firms, and we don't need you, messing with the program here. And that's when I think it was Joe Rogan said, So what'd you do next? Well, I went and endorsed Donald Trump.
Yeah.
So
I mean, A16Z is they might be the best investor in AI.
Yeah, and so the message from that release was not that we're going to get all these things, because some of those things are already underway. Building those data centers, it's already underway. What he's actually saying is, you're not going to stop the train, to those people in the...
Well, so let's just make it clear. He rescinded the order.
And
then 2 hours later held this press conference and announced a new plan to invest $500 billion.
Yeah. So first of all, to the people who wanted to control the development of AI, which became a big hidden message in the election. Basically,
yeah, you're not going to.
You're not going to.
Which I think is healthy, probably. I mean, we don't want regulatory capture at this stage of AI.
Well,
in my opinion.
and not AI, right?
Yeah.
And the second part of it is, he's showing some cooperation with the tech industry that I think is kind of important. Larry Ellison's comments were kind of loony, to be perfectly blunt. But
he was talking about mRNA curing cancer,
right?
Which I'm not sure there's a lot of evidence for that.
It's one of the least promising areas of oncology.
Yeah. And then a day later, Elon Musk, who couldn't be tighter. I mean, he has an office in the White House.
Yeah.
He's very connected there. You would have thought they would have their messages coordinated. But he came out and said there's not $500 billion there. And he pointed out on the balance sheet of all these companies that were named, there's not enough money.
Well,
which goes to your theater thing. It was a good press conference, but maybe not that real,
right.
Or at least not $500 billion.
I will not argue with their intent. I think the intent is still there. I also think everybody needs to get comfortable with people like, Elon Musk or Scott Bessent or anybody popping up, Robert F. Kennedy, and showing some disagreement with the president. And that's really unique. And we haven't seen that in, 40, 50 years. So it's hard to get used to.
And will Trump be okay with that?
Oh,
that would be good. It would be good if
I think that's actually part of what he has been trying to communicate. Mm-hmm. When people are, well, you're so and so said this and you're saying that. Like, great example, Robert F. Kennedy. Somebody says, well, Robert F. Kennedy's going to do all these, things. And he says, well, I'm putting him over there because we don't agree on the environment. That Robert F. Kennedy does not agree with me on what we're going to do in the environment. So he's going to be over at HHS. So
he's not on EPA. He's
not on EPA.
Yeah,
but his point being is you're not going to, if you find a bunch of people to staff a
that are all identically, have the same philosophy on everything.
You're not going to get much talent.
Yeah,
and that's been true of Washington now for 20 years.
Yeah. So then the Wall Street Journal ran an article saying pension funds are pushing private equity to open up about fees and returns.
No way. Really?
Which, they have been doing forever. But two things caught my eye. One is that the investments have been going up pretty dramatically into private equity.
Mm-hmm.
It hasn't really filtered into the venture market of private equity. I think it's later stage. But then the fees, the median is 2 and just flat at 2, which is the standard 2 and 20. But the average, which I think means that the bigger funds, it's probably a dollar weighted average, I assume, are willing to accept less than 2%.
Right.
Which they should, really. I mean, there's a lot of fixed costs in investment businesses. And so the cost to run $100 million is not that dissimilar from $50 billion,
right.
But obviously the 2% is a lot more.
Right. Well, what's really the real problem here is that those investments are not performing. It's the same. It's the same issue with a lot of the pension funds asking the hedge fund industry, "Hey, there should be a cash hurdle.
Yeah.
If you can't hurdle a cash rate, why should I pay you anything? I'm better off in cash."
Yeah. Right.
And I think this is really same expression or a different expression of the same problem, which is, why are we paying?
When
fees?
Everyone's making 3x at the fund level and really strong internal rates of return, you can stomach the fees. And when it falls down, then they look for anywhere to sort of
right.
catch up.
And they have a very reasonable case for saying you're not performing.
Yeah.
And that this we pay you to perform, so we
Yes.
should pay you less if you don't perform.
Yeah.
That's how it works.
Trump had several executive orders in the first day, and many impacted healthcare. This article on Fierce Healthcare sort of goes through several of them. But I want you to sort of take it in any direction you want. So the first one in the article is a regulatory freeze at HHS.
Yeah, that's going to affect some of the drug price negotiations. It's definitely going to affect the Wegovy expansion of Medicare coverage for weight loss drugs, among other things. But this is not abnormal. This is not unusual to say, all right, stop. We're going to get a handle on these
New
rules.
administration comes in, they often will stop in the first part of it.
And it's generally not particularly controversial. So that this is not anything to be upset about. A lot of news organizations are reporting it as it's new. It's just really new to them, not actually new. One of the other things that they've frozen is some drug models, that came from the model system comes to us through the ACA. I fully expect the CMMI to get yanked completely and to be.
I think Biden shut it down before he left.
The CMMI, no, it's still a department of HHS. It just underperforms massively, and Congress is like, you're not delivering on your promise, and they want to get rid of it. So I think it ends up in reconciliation as a pay for. It's not a lot of money, $5-10 billion maybe. So all these models need to stop anyway because they're gonna that whole approach is going to be dissolving. And remember, the CMMI was created to help bend the cost curve. Remember the cost curve? And, that was the whole reason for the Affordable Care Act.
I think, Marcus and I talked about it, as Biden was leaving, he made changes to CMMI, but we need to check.
Yeah.
But either way, it's going to get
axed.
Yeah,
I'm pretty sure. And it didn't work.
Right.
And the hiring freezes, that's also fairly normal.
Yeah.
We pulled out the World Health Organization, again, not particularly.
But let's talk about that for a minute. We pulled out of the World Health Organization.
Right.
And
so it's going to be half a world organization.
Yes. It'll be a half. I like that. So CDC won't get health data from other countries, but I don't know how much that matters. And so the interesting thing is we pull out and there's not a lot of repercussions, really.
No. And Bill Gates is their second largest donor, and I don't think he's going to, dissolve his commitment. So they're still going to have.
Yeah, it'll still exist.
Still have that. And I don't. I mean, what's the value add to American taxpayers there? Is it we're helping other people around the world be healthier? That would be nice, but I don't think there's any evidence for doing that either.
Well, just to steal me on the other side, I'm not sure they are very effective at doing this, but I think it would be valuable for us to take the position that these communicative diseases, if they start in another part of the world, we will get them. And so monitoring outbreak in different parts of the world is valuable to us if they are able to do that successfully and find it in wherever it is, another part of the world, and then catch it. Hopefully fewer people die there, but also they don't get on planes and transport it. Now, when we had COVID, WHO was certainly in play, and it didn't stop it.
Yeah, and the question is are the national organizations that monitor infectious disease and the health of their citizens equally as competent to communicate to the world that they found this thing in Cambodia or Thailand? Probably, right? Yeah. So it could be that World Health Organization, sits on top of all of those organizations to organize them, and maybe it's better organized, but I don't know. When it comes to public health and life and death, most people will organize themselves around what works the best. And so far, I don't know that the World Health Organization has produced results either.
Yeah, I mean, if it was well run, I think you could have sharing best practices. There could be functions that a global body could do that would be useful, but I don't know that they have been.
It's a cushy sinecure in Geneva. Who doesn't like that?
Yeah.
Come on.
Okay, so
this is
this is the big one. So this is the title from the Wall Street Journal.
Yeah,
because it's provocative. Trump's war on DEI freezes diversity work across the federal government. And I know you have a lot of thoughts about how this will impact healthcare. So talk about this and what the ramifications are going to be.
Your first thought when you look at that headline is, oh, okay, we're going to freeze that. Okay, all the HR, diversity, equity, inclusion, and accessibility programs.
Yeah, at the Internal Revenue Service, they'll have to not do a DEI program or something like that. That's what I thought.
And those employees would now have been they're on paid administrative leave, and what's going to happen over the next few months is they're going to figure out, okay, which of those employees are redundant, which of those employees, should be reassigned to other, functions.
Yeah, and they might have a review process that they need to make sure it doesn't include DEI or whatever. It's HR. I thought it was an HR story.
Yeah, but what's included in the executive order is that we're not just shutting this down the government. We're not going to preference it with the activities of government, which is grants. Okay, so grants and any kind of funding.
That phrase, "we're not going to preference it," confuses me.
Well, we're not going to give you a grant. Given Academic Medical Center A and Academic Medical Center B, let's call them, say, University of Mississippi and Harvard. All right. Under the previous administration, we would give preference to Harvard because they had this DEI program that was part of our objectives as an organization. And I haven't looked if the University of Mississippi has it. My guess is probably not. But what they're saying is we are not giving grants to people who use our money to support, meaning the federal government's money, to support that kind of programming in their university.
Yeah, it's a little bit more far-reaching than we're no longer going to give you a preference.
We're not going to support others giving that. They're extending it to.
So if you receive grant monies from, say, NIH, is it right to say you cannot have a DEI program, or you can't have a DEI program that is touching that money?
That's unknown. So that's the big question. Are you saying when the NIH says, all right, we are not going to give preference to entities, sponsors of research that have DEI programs? That's one way of looking at it. Okay. Another way of looking at it
But there might be other things that Harvard could have that would make it more likely to get a grant than University of Mississippi.
It could.
They still might get a lot of grants, I guess.
It could. Yeah. They could, yeah. But the government is going to say, all right, we're not interested in giving you money to support your university or your research programs if you're going to support these policies that we think are adverse to the principles of the federal government. That's what they're saying. Okay. Now, how far does that extend? Is that just, the research entity? Is that the academic medical center? Is that the whole university? I don't know.
They haven't defined it yet.
They have not yet defined it. What they have done is suspended the study committees, which are a preface to grant funding, which tells you they're trying to figure it out as well. But I would
it's at least going to be so. A lot of our listeners are connected to academic medical centers. I mean, we have one here in Nashville at Vanderbilt,
big one.
But there's a lot across the country. I mean, almost every state has an academic medical center, and several have multiple.
Right.
So I pulled up a list of who gets this money. There's a government contractor that's doing government biomedical research that gets the most money, which let's not get into that right now. But Johns Hopkins,
number one.
Then the California system, University of Penn, Duke, Michigan, Mass General. I mean, it's the people you would expect.
Yeah. And nobody at those organizations voted for Donald Trump, or I should say very few voted for Donald Trump. So I don't know, I think it's a big mistake to think of these actions on the part of the president, these executive orders, as retribution of any kind. I think it's more probably accurate. Oh, there's Alabama down there. It's more accurate to think of these actions as the federal government is supporting policies and activities that are contrary to the goals of the president and the federal government. Okay. And while DEI can be a laudable goal, and I think everybody agrees that it is, institutionalizing that can be unproductive. It can create activities and activities and relevant to our conversation, the awarding of grants that isn't necessarily productive. It doesn't produce results.
And whether people that work at these academic medical centers voted for the current president or not, elections have consequences. He won the election.
Right.
And his administration is putting this in place. And so what I want to talk about is what's the impact to Johns Hopkins or any of these institutions, because they're running medical centers, and a lot of them rely on grant funding as a significant
20
part,
to 30%,
significant part of the budget. And so it sounds like has a chance of being delayed, and then maybe a small-ish chance, but some chance of being cut or changed.
Right. So before you get into the DEI, you got to know that the Senator Cassidy on the Senate side has made an issue of funding NIH really around the way in which it coagulates around these 25 or so large academic medical centers like Vanderbilt and the Icahn School of Medicine at Mount Sinai and so on.
And we'll have a link in the show notes so people can check this out. I mean, it's all the names that you would guess, but right. there's an 80-20. Like it's the normal expected way that these funds are given out. There's a group of 10 that get a lot of the money, and then there's another group of 10 to 20 in that sort of ranked 11 through 30, 25 or 30 that really, that's where most of the money goes.
Yeah, where's the University of Tennessee on this list? It's tiny. I think
little ways down.
Yeah, and so the already, before going into the election, before we're even talking about DEI, what we know is that there has been a policy, an interest in shifting the policy away from these large universities. Okay, that became
interesting. Senator Cassidy,
or getting it to be more fair, or getting
or more spread geographically into different institutions.
Right. And that became really clear, when after when we had these university presidents testifying, from Harvard and Penn, and who else was there? Penn. Anyway, they're doing this, they're talking about, October 7th and anti-Semitism and failed miserably, right, in front of this group of people. And sort of demonstrated, at least from Congress's point of view, is this group of people have completely different values. Now, those values may be they're worried about, kids from countries, that are paying cash that aren't particularly aligned with, some of these values. It could be just economics. We don't know.
Yeah, but that's not what they shared on the Senate committee floor.
It could be, but most likely is that the values of the government, if you will, don't align with these universities. Yeah. And that is now more true today than it was, a few months ago. And so that's really what's going on. So if you're a university, if you're Johns Hopkins University, and I'm going to bet this is what happens there, you have a few choices.
Yeah, so in 2023, just for context, Johns Hopkins received $842 billion in that 1 year in NIH grants.
Yeah, right.
And I've looked at several years. It's fairly consistent. I mean, there's some moving around, but they get a significant amount of money every year.
Yeah.
And so if that dries up or is delayed, it's going to be
delayed.
challenging.
It's going to be delayed. There is going to be a hiccup in
Yeah.
the system. So the purchases of research equipment, tools, consumables, that is going to be delayed. There may be layoffs. There may be leases negotiated. There may be all of those things are likely to happen in the next 3-6 months. Okay. Now, if you're Johns Hopkins and you get the message from the federal government, we're not going to support you because you support programs that we think are adverse to the American taxpayer, DEI being the one at issue here.
25% of your budget.
And it's 25% of your budget. You have a few choices. Your first and obvious choice is to just get rid of all that stuff, okay? And say to all of your, faculty members and all your researchers.
Yeah, you have a staff issue, but you then get the money back.
Right. So that takes a strong leader, which is not
always present.
Not always present in large academic centers. Your other option is, at the other extreme, is to ignore your government and not do that, which is going to cost you some big money. And then there's going to be people who are in the middle where the leadership of the research entity, Johns Hopkins or wherever, says, okay, we're going to get rid of all that. We need to conform with federal policy. We're going to end our DEI programs. We're going to reassign people here. We're going to have, blind admissions as far as race, creed, color, et cetera goes. We're going to do all those things. And your faculty goes nuts. That's going to be the real pickle for some of these guys, because there are a lot of people employed at these organizations who are first and foremost very adverse to the current president of the United States, but also this is a closely held belief of theirs, and they don't want it to be disrupted. And that's where I think the real challenge will be. And I hope that doesn't happen.
There's a lot of feelings and beliefs and emotion on both sides.
Yeah.
And I want to end by saying, this is medical science we're funding.
Mm-hmm.
Can't we just do science?
That's right.
I don't know how to get there, but and I'm not saying that. I mean, Trump is sort of picking a fight, and so no side is right or wrong. But it should. I would like the NIH to award grants to the institution that is going to do the best science for the country.
Right, and I think that
maybe that's just
naive. I think
naive.
the incoming head of NIH would agree rather wholeheartedly with that. Mm-hmm. And I think what you will, if you start digging, and John Iadinas at Stanford had written a great paper on this about a lot of non-productive activity. If you have a mandate at NIH to deliver research to a certain portion of grant applications that meet certain criteria under the rubric of diversity, equity, inclusion, accessibility, and those aren't particularly good research projects, then what you're doing is wasting the taxpayers' money.
Yeah.
If you want to get right down to it, okay?
And someone else can fund that.
Oh yeah.
I mean, I'm probably in favor of that, but I don't know if the NIH should be funding that.
And I think that's really the point. And you need to get involved. You need to think about this as hardcore science and hire hardcore scientists. Don't hire them because of the circumstances of their birth. That's the message. It is controversial, and it is going to be really uncomfortable, because one of the things that characterizes these academic research centers is their lack of circumspection or introspection when it comes to these issues. And this is going to be tough, because a lot of people are going to feel they're shocked. I was talking to somebody at lunch whose old roommate wrote some of the scripts for the the university heads that testified, about anti-Semitism in Congress, and they were shocked. They were shocked by the reaction they got, and you need to probably get out more if that's
right.
If that's what happens to you.
Yeah. Okay. So that's going to be really impactful to a lot of health systems. Yeah. Okay, and then Trump also froze HHS communications. Several websites are not functioning.
A lot of 404 error out there.
Yeah. Is this also norm? I haven't seen websites go down in the beginning of it.
I've not seen this either, and I think because I think this is good management of communications, even though everyone probably would disagree with me, because President Trump has made some fairly bold departures from policies that date back to 1965. Okay, that's how radical some of this stuff is. I think this radicalism is being embraced by a lot of people. He's not getting out of his lane yet, but he's really doing some pretty radical things. And in order to keep yourself from being embarrassed, you got to have to shut it all down, because what you don't want is HHS sending out an update on their diversity, equity and inclusion and accessibility policy at the same time that you just issued an executive order saying we're not going to do that. So this is really the only thing you can do at this point.
Yeah, and do we think this is a short-term issue?
Oh, yeah. I wouldn't expect this to last more than a couple weeks, maybe even less.
Okay.
You got to get the comms people in there and get, the policies, set up and so forth. So,
yeah. So this is the Wall Street Journal. Trump order seeks to stop virus research that critics have linked to COVID.
Yeah, well, Barack Obama did this too. Dr. Anthony Fauci ignored him.
So this is the gain of function research.
Yeah.
Just to be clear, it sounds like Barack Obama tried to stop it, and now we are again trying to stop it.
Yeah. And what happened was that because the whole gain of function thing, that is a biowarfare thing. That's not really it's not going to make people healthier if you do that in most cases.
It's a DOD.
It originated with DOD and specifically originated with Dick Cheney. Dick Cheney went to DOD and said, hey, we need to come up with all these viruses that might actually be a challenge for us militarily and domestically. Will you do this project with the Department of Defense program called DARPA? And they said no.
So hold on, that sounds more defensive, for our own people. To protect ourselves.
The idea is to create a virus, and when you create the virus, then you know how to create the inoculation against that virus. That was the whole thinking back in 2000 and 8, 7, 8, somewhere in there. Because remember, George Bush got really worried after the anthrax scares, and he read a book about yellow fever in Memphis, which I'm sure you're familiar with, and he made this a big part of his presidency it's sort of by midterm, late term. And Dick Cheney was kind of looking to solve that problem, and he goes to the Department of Defense and says, hey, how about we develop this research, virus research, and then we can develop the
And DARPA has invented and tried to invent lots of really effective ways to either protect our troops or kill the other side.
Right.
And they refused to do it.
And they basically the documentary evidence from the Department of Defense is, and it was the same group that ended up doing the work at subject to all the controversy over COVID, and that's something called Echo Health Alliance. And there's documentary evidence where the Department of Defense has said, we're not doing that. And if we're doing that, we're not doing it with you. That was what happened. And so Dick Cheney goes to NIH, which of course they're tinkling test tubes all day long, right? And he says, all right, why don't you do this? And Anthony Fauci, who's head of infectious diseases, said, yeah, sure, and Obama, there was a little bit that created some controversy, particularly from Richard Ebright at Rutgers. He made a big stink about this and still does on Twitter. He's very entertaining. And it reached the White House. Obama bans it, but they find this way around it, and continue to fund it.
Yeah, they funded it outside of the U.S., I think.
They funded it in China. And that's where this comes from. I don't think there's going to be a workaround this time like there was then, because the defense, the Dick Cheneys, the kind of the defense,
the neocon,
they're being excommunicated right now. Yeah, so I don't.
But that's probably good, right?
Yeah, there are very qualified and serious scientists who have said for 2 decades, this is nuts.
Yeah. Yeah. There's no reason to invent something that is very contagious or very effective at killing people. That we shouldn't do that.
Right. And part of that whole theory too is centered around, well, humans are incurring, they're entering habitats, and it's kind of connected to the climate change thing. They're entering habitats, and as they enter those habitats, they're exposing us to, bats and so forth. Well, the truth of the matter is we're not really entering that many habitats anymore. The population,
we've taken over all the habitats.
Yeah,
mostly.
or they're receding, because we're not actually actually occupying certain places like we did. Just, look at downtown Nashville.
I don't know. I was driving through today. It was pretty busy down there. So. Okay, then
this is also huge.
Yeah, so the House G.O.P. floated Medicaid cuts and a bunch of other things to finance really the extension of the tax cuts, but all of Trump's agenda. But let's talk about forget why they're doing it. They're trying to cut expenses.
Right.
What they came up with, the top one is, it's in this New York Times thing. It says longtime conservative goals like slashing Medicaid.
Right.
When you read through it, I think it is changing the percentage match for the expansion population. So
which
I think
was never meant to be permanent.
Most of our audience probably is aware of this, but Medicaid is a 50-50 cost share between the states and the federal government.
Depends on the state, which is also the subject of debate right now. But 50-50 is a good thumbnail number to use.
And then if you expanded, really, I think to encourage expansion, the expansion population is covered at 90%, 10 to the states.
Right.
And so they're looking at that equation. Like, should it be 50-50 and then 90-10? And what do you think what's going to be the resolution? Where are they coming out on this?
This is probably going to make its way into reconciliation, and because it's such a big number. Over 10 years, I think one number I saw was something like $500 billion. So if you're trying to cut 2 or 3 trillion, that gets you pretty far down the road, right? And what they're trying to do is equalize the federal government's contribution to Medicaid programs between traditional populations, aged, blind, disabled, elderly, pregnant women.
And we're in the 50% probably.
Yeah, they're
in the normal Medicaid.
They're the traditional populations, okay, and the match is 50%. But if you're in the expansion population, which means you are you could be a working adult, okay? You could be you might be working in a job that doesn't have healthcare benefits. You might be
you'd have to be relatively low paid.
Right. Or you're working in a job where the cost of those benefits is so high, you manage to, work your way into the Medicaid program. And what that message is, and this is the argument from, and it was always meant as an incentive to get states to go along with the expansion. It was never meant as this permanent thing. And one of the problems there philosophically is the federal government is funding able-bodied adults better than they're funding pregnant women. That's not a really good policy, no matter how you look at it. And it's contributing to a lot of bad behavior. So states, and the example I give a lot is a pregnant woman enters the program, Medicaid program. She's in the traditional population because she's a pregnant woman, and there's a 50-50 match. She has that baby at some point, and she's supposed to move to the expansion population, but frequently states don't reclassify people. So the level of fraud and misassignment, because the incentives are, the
incentive would be to move.
I'm sorry, I meant to. They move her to the expansion population, or they enroll her as a pregnant woman in the expansion population to begin with, and those are incentives that are just creating enrollment in the expansion population that is not necessarily was the intention, and there's a lot of
so
fraud.
Do you think it will be sort of normalized at 60% or something, or what would be
here's what I think is going to happen. There's several policies. One is cutting the match to the expansion population. Another is lowering the overall federal match. The floor is 50%. So no matter how wealthy your state is, you'll always be able to get a 50% match. In Mississippi, you might get a 65% match. All right. But in California, it's a very wealthy state still, or Florida, you get a 50%, lowering that floor, to maybe 40%. Okay. And another policy.
And how do they judge if a state is wealthy or not wealthy?
It's a calculation based on poverty and population and stuff like that. So the other policy is to implement per capita caps. So what I expect to happen here is the federal government will cut spending to the Medicaid expansion population in reconciliation, and the states will go nuts. Okay.
Yeah.
And what the federal government would say, okay, you're right. You're right. This is a hardship for you. Okay. So, and you're going to have all this population you've got to deal with. You're right. So how about this? How about if we work with you for a 1115 waiver, which is how states operate their Medicaid programs, and we will come up with a program, a block grant or a per capita program, where you will basically be made whole at the beginning of this 5 or 10 year run, and we will flatten that curve so that when we get to the end of that 5 or 10 year period of that waiver, you're where we would want you to be if we just cut spending. Does that make sense?
Yeah. So let me just rephrase to make sure I'm following. So today, I forget which state, but California, they're getting 50% for their regular Medicaid program and 90% for the expansion.
Right.
And there's like a 2-step dance that you're proposing might occur, although we're guessing now because it will happen in reconciliation.
Right.
But you talk to a lot of people up in D.C., so let's just go with this for a minute. So they might, in reconciliation, cut the expansion to match the 50-50, for instance, and then allow states to go with that option.
Right.
Or
which would disenroll a lot of people from Medicaid, although they could go to the Affordable
Or it would make it
Care.
very expensive for the state.
Right.
Or some combination of both.
Right.
That would be what happens in reconciliation and, in fact, the federal law. But they also would be willing to negotiate a Medicaid waiver with whatever number you said that could do a block grant, which would be based on their population. That's why you call it a per capita. But it's a block grant to the state Medicaid program.
Right.
That is maybe, let's just say, equal to what they got last year.
Right.
But it's not going to grow at anything more than like maybe a CPI inflator or something.
Yeah.
So,
or maybe flat,
Yeah. So for the immediate needs for the governor of that state,
you're not screwed.
You're not screwed.
Right.
But you have this ticking thing that in the next 5 to 10 years, you're going to have to figure out a way to deliver healthcare to these people and fund it, or you're not going to have as much healthcare.
Right. Yes, exactly. And another policy that's part of that is something called supplemental payments. And hospitals and nursing homes in particular, what they do is they'll agree to pay a tax, a bed tax,
right?
And
then they get back somehow,
and then which they basically get back times 2. Or even more than 2. And this is long-standing policies have said this is a bad idea, because it creates incentives that should not be there. And where we are right now is, quoting one, investor relations head at a large publicly traded hospital company, we are now agnostic as to who pays us, which is a very, very different environment, because we've got supplemental payments from Medicaid, we've got this, we've got that, and so that would also probably be part of those deals as well. And if you want a template for that, you go back to 1986 when, under Reagan administration, as part of the tax cuts and the budget, changes of the budget, there was a law, TEFRA, which essentially gutted Medicare. Okay. And of course, all the hospitals are screaming bloody murder. And that's where the prospective payment system came from. Like, oh, okay, you don't like getting this to happen? Well, here, we're going to come up with this. And that's how you got them to the table.
Interesting. So, but no matter what the details are, it seems like the direction that Congress controlled by the Republicans, is likely in reconciliation to cut Medicaid in some form or fashion.
Yeah.
Whether they do it in exactly the scenario laying out or some ever the variety, it seems clear that it's going to be pretty difficult for health systems. There'll be less money flowing over time.
There is no doubt that there's going to be less money flowing over time. That is, you have got to revert to the mean. And if you look at just say an employment chart of healthcare in the United States, it's got two major hookups. Until 2014, roughly, it was following a 2% trajectory year over year.
Number of employees in healthcare.
Okay.
Businesses. Yeah.
2015 implementation of the Affordable Care Act, we bent the cost curve up.
Right. and we had a lot more employees.
And then the other big bend of the cost curve up, was under the public health emergency. Yeah. And so you've had these, like I call them the three epochs of healthcare, before the Affordable Care Act, the period of the Affordable Care Act until the public health emergency, and then the public health emergency to where we are today. And what's going to have to happen is you're going to have to get back to some inflated version of healthcare prior to the Affordable Care Act. Which, by the way, means you're freeing up money for wages, cash wages, because you're driving down the amount of money the government spends on healthcare, and therefore the taxes that are spent on healthcare, and therefore the whole regime gets disrupted.
I was following with the cost has gone up and then up again in the two new epochs,
as defined by the number of people employed. Yeah.
And then it seems like this new administration is going to cut. Certainly in Medicaid, they're talking about it. They've previewed it a lot. How that frees up money for wages. You mean wages overall, not necessarily healthcare wages.
I don't mean healthcare wages.
Yeah, it's going to be negative to healthcare wages.
Yeah. I don't mean because what you have to do is get the cost of healthcare back to that trajectory pre-ACA. Just that nice.
So Jumpstart, we're too small, but Jumpstart, we have healthcare benefits, and so your point is if that cost begins coming down as a percentage, I can pay my employees more,
right?
Which might be good for society and good for business.
Correct.
But it's the point that I'm trying to make sure I understand is over the next, say, 5 years, health systems and physicians and all of the ancillary vendors and providers related to the healthcare system, the pie is getting smaller.
Right. All those things are costs, and all those things show up in your insurance premiums. Yeah. That's the bottom line. Your insurance premiums are an expression of all of the costs that go into that system. In the aggregate, in the macro level, I'm not talking about your particular.
Yeah. So, it's roughly, at a macro, it's 50% employer-based and 50% government-based, something like that.
Yeah.
The details more, but rough math. And so, yes, it will benefit employers and employees eventually because there's more money to pay them, and it'll reduce government spending, which maybe would flow to tax cuts. But the more immediate thing for my portfolio companies and for a lot of listeners here is that the growth in healthcare spending is going to slow down or maybe even decline, negative growth.
Potentially, yeah. And you combine it with demographics, that could happen.
Yeah.
And one of the pitches from Robert F. Kennedy, who's going to testify on January the 29th for his nomination, is that we spend too much on healthcare because healthcare sells too much. We spend a lot of money on it, and we have all these reasons for spending money on it. But and the flashpoint for this is the anti-obesity drugs like Wegovy and Ozempic.
Yeah.
And where you have this drug that's, $1,200 a month because the food supply sucks, or the people that a certain portion of the population is relying on the potato chips we were talking about earlier, and their ability to manage their health properly through the nutrition that they get is compromised. And his point being is if we could get to that problem, we don't have to spend as much money on.
Yeah, we would have healthier people.
Right. And if you and this I think is the big paradigm shift, which is if you think about the fight over the Affordable Care Act, which was gruesome, and I'm referring to the repeal effort in 2017. It was just gruesome. You had people coming into, wheelchairs into the Senate gallery. You had people falling out of wheelchairs, crawling across. There was just this concentrated coverage of people who were sick. And sick. I'm not trying to denigrate their condition, not at all. But the focus of the Affordable Care Act and the focus of the federal policy is this presumption that a lot of people are sick, and we need to take care of a lot of sick people. Whereas here they're saying, we want everybody to be well, we want everybody to be healthy, and that's It's not easily detectable unless you do what I do, right? But it is a definite shift in the way in which you think about your policy from, oh gosh, Bernie Sanders is very fond of using, nobody in America should go without fill in the blank, x-rays or mammograms or whatever, to let's talk about what you're eating. That's a huge shift.
But you could do both, right?
I think so too, and I think you will. But I'm talking about the focus of the policy.
Right. Yeah. So the Robert Kennedy and others are going to focus on food, and maybe they'll cut drug TV commercials or things like that are I think in most people's opinion not contributing to the population being healthy and well.
No. Because what's the message there? Call your doctor. The message is, and people do. They call their doctor about this thing that they think they have. And,
right.
And, and like WebMD, have you get this.
I want to have sex on, on a pool, in a pool overlooking the water. That if I just get this little blue thing,
then everything works.
Everything works.
Yeah. And so but that's the real shift here, and it means you're going to spend less money on healthcare.
Yeah. One of the things that's being floated is that there are many hospitals that are nonprofits. Most are nonprofits. I agree. And as that status, they don't pay taxes. They don't pay federal tax. They don't pay local tax. They don't pay state taxes. They don't pay taxes.
Right.
And I was questioning how likely that was to actually come around, and you shared this story from Marty Makary, who is the incoming head of HHS?
FDA.
FDA.
Yeah.
FDA. What's Robert Kennedy going to do?
Robert Kennedy's Secretary of HHS.
He is HHS.
Yes.
And then Marty is FDA.
Jay Bhattacharya is NIH.
Okay.
Dave Weldon is the CDC, and Mehmet Oz is the CMS.
Yes. Okay. And so
all doctors.
Dr. Makary put out this article on Stat, which we're looking at and we'll link in the show notes, making the case that hospitals should pay taxes.
Yeah. And believe it or not,
obviously, publicly.
This isn't even a Republican thing, which is what makes it so dangerous. Okay. It was actually Bernie Sanders who has raised the issue of the nonprofit status of American health systems. If you're running a big American health system, you're being paid pretty nicely. Okay. And one of the arguments that the CEOs will give to their board is, well, if he went to HCA, he would get options. You can't have options when you're running a nonprofit. That argument gets floated a lot.
Yeah, I think that's accurate.
And it is accurate, except you're at a nonprofit because you're supposed to be helping the community. Whereas over there at HCA, I guess you're doing something different. I don't know. I'm joking around. But the Bernie Sanders has been on this, okay? And the Republicans have been on this. So this is so dangerous because all of a sudden you have agreement. And what has contributed to this problem is high-profile health systems taking their patients to court because they didn't pay their highly inflated bill,
Right.
and garnishing their wages and ruining their credit and all sorts of other practices that if you had stopped to think about that just for 5 minutes as a nonprofit hospital, however many hospitals you may have in your system, somebody with a brain in their head should have said, that's kind of a bad idea. We probably shouldn't do that. But they did, and that caught a lot of people's attention. Now, I do not think the nonprofit status of hospitals and health systems is going to disappear.
I mean, I don't know how the country could take care of the patients that we have to take care of, because that just flipping that switch would be very difficult.
You wouldn't
to do.
flip that switch. And here's what Bernie Sanders really wants, and that is for the IRS to articulate a set of standards that makes a hospital or health system nonprofit. When do you cross that line where you really are, as Bill Carpenter, who ran LifePoint, said one day in at a investor meeting, well, they're non-tax paying, not nonprofit.
Yeah. All the Nashville for-profit operators refer to what we would traditionally call nonprofits as non-taxable,
right?
Yeah,
and
because there's a lot of return, money that is left over after they pay expenses.
Right. And they have no cost controls. They're notorious for that. They're notorious for overemploying. There's all these things that the rigor of some standards might actually help get things in line. So what I expect to happen is that the IRS is going to come forward, and I don't think this is going to be on the short list of things to do here. But
this is going to take a while.
It will, to come up with a set of standards that you would have to adhere to if you're a nonprofit hospital. That will probably have something to do with salaries. That will probably have something to do with, suing your patients. That will those things that define, because if you're working for a nonprofit, you're supposed to be accepting that there are certain restrictions on your personal achievements, particularly monetary. At least that's the way it used to work, right? It doesn't work that way anymore. But what could also happen is some of these successful nonprofits could convert to for-profit.
Yeah.
And that wouldn't be the craziest thing in the world. The capital markets are free and widely available to them, and a lot of them have got great businesses. And
I think you have three types of nonprofit health systems, right? There's the, fully scaled, very well run, like Common Spirit, Ascension, Kaiser Permanente. They have a new brand, but those platforms you'd put them right up against HCA and LifePoint, and they're good operators, right. And they could transition to be for profit, or they could abide by whatever new rules come out.
My guess is they're going to be for profit.
Yeah. And then you have the academic medical centers, which have the
problems we've already
grant
discussed.
issues, and they are subscale. And I don't know that they would be able to transition, but it depends, I guess, how they configure themselves.
Right.
But they're actually better positioned than the last group, which is the subscale, like community hospitals, where you maybe have 3 hospitals somewhere, and you don't have the academics for the grants, but you also don't have the scale and the executive team.
And there might be, but you also probably are serving your community a little bit differently.
Yeah, they I think will have to abide by whatever these new standards are, and that's probably okay.
Yeah, I think that's probably fine.
Yeah.
So,
but this is a pretty the reason I wanted to cover it is it's pretty dangerous thing to have being bandied about, because there's a lot of states and cities that also have financial troubles and would really like to get the real estate taxes and the other whatever the local taxes.
This topic has been openly discussed here in Nashville relative.
I didn't know. Yeah, so the Nashville politics.
Yeah, this has been openly discussed. Is that there's a lot of tax-free property in Nashville. We have Ascension and Vanderbilt, right? In Midtown as 2 examples.
Yeah.
But And you pay property taxes on those parts of your business if you're Ascension or Vanderbilt that meet certain standards of profit making. If you're running
so they do pay some property taxes.
It depends on the function.
If you're running an outpatient surgery center.
If you're running an outpatient, no, but say if you're running a bookstore, Vanderbilt's bookstores now, of course, outsourced, but so that might not be a great example. But there's often a component of for-profit that doesn't meet the requirements.
But the amount of money that Nashville would collect would be much greater. I mean, Vanderbilt. Well, both of them, Vanderbilt and Ascension, have a big footprint.
Yeah, this is all under consideration already, and you start when you need revenue, you start looking everywhere, and this could be one of them. So yes, it's a very dangerous idea, but probably one whose time has come. And I think the nonprofits have really, some of them, nobody to blame but themselves.
Yeah.
I mean, garnishing your patients' wages, really?
Well, the only thing that I know
Virginia did
is that they will blame someone else besides themselves.
That's true, yes.
Okay, so CMS is appealing UHG's win in court about their star ratings. This story will not die, and I don't understand it. There was
star ratings are produce significant bonuses for the managed care organizations. So if you get downgraded in your star ratings, you lose revenue from the federal government. That's the bottom line. All right.
Yeah, and United's court case, and it's in Fierce Healthcare. I haven't fact checked it myself, but I've seen this story now 3 different times.
Yeah.
They won the court case because they got the D grade from 5 stars to 4 because there was one foreign language test call that was disconnected before they could evaluate it. And I don't know how that's going to be appealed.
Well, the first thing to understand about this is there's probably a little bit of trying to get the payments down to managed care organizations because the progressive wing, Elizabeth Warren on one side of the hill, Alexandria Ocasio-Cortez on the other side of the hill, are giving CMS a lot of pressure to how much money that is going out the door to non-traditional Medicare. So part of this...
Hold on. The progressive wing is pushing for cuts?
For managed care, yes.
Cuts to managed care companies.
Because that would be good for traditional Medicare, which is not privatized. And so that pressure very likely...
I don't know how one equals the other.
I don't either, but I'm just telling you. But the result of that pressure has, I think, contributed to a few things. One, the deceleration in payments, annual updates to Medicare managed care organizations in the form of the Medicare Advantage payment update. All right. And if you listen to United Health Group's earnings call, Andrew Whitty refers to the latest update, which is over 4%, which we haven't seen in a while. And he says, they're getting more rational than they have been in the last few years, which is
we covered that last week. The physicians and health systems were upset about it because it was higher than what they got.
Exactly. And what's happened and what they were probably doing, and the star ratings as part of this, were getting pressure, and we wanted to fix the pressure. The fact of the matter is I expect the star ratings to go away. Because, and this is...
It's been a train wreck. I mean,
it doesn't work. And they keep loading it down with things that shouldn't necessarily be there. And it's contributing to the cost of healthcare. For example, you get an improvement, you get a points, or if you will, if you're prescribing statins. Statins are controversial. Not everybody should be prescribed them. And the doc should decide based on, the patient in front of him, not the score, that you're getting from your Medicare Advantage plan. So I expect them to go away. What they'll do is they'll fold it into the overall payment, so there won't be any decline in payments, but I think that's going to go away.
Okay, and then Elevance announced their earnings, and they grew well. Membership's growing at least 7%, maybe 9%. So Elevance is probably the best performing MA plan.
They are. And if you look, though, at outside of MA, well, even if you look at MA's got some, Medicare Advantage got some consolidation that's going to go on here. So you're not going to really see it right away. But when you look at the Medicaid, managed care organizations, and the Affordable Care Act, and the deceleration in enrollment in those, I think the picture for the managed care organization is much bleaker than it is for the providers, because there's one of the kind of the root problem is if you add up all of the number of people insured by something in America, my model is 320 million people. There's about 340 million people in this country. You're not going to find that last group of people. They're on the dead end road, in Utah, right? At the end of the Box Canyon. But you don't have any growth in.
Yeah, the boomers are going to begin to pass away.
Right, they're already doing that.
And my generation is not going to fill in.
You're not going to fill in, right? So you're
going to have less numbers in Medicare Advantage over time.
Yeah, so you have that demographic problem. At the same time, you have these changes in Medicaid and the ACAs. And the fact is, you everybody's got health insurance in some way. So there's no enrollment growth for these managed care organizations. So then it becomes a question, all right, well, if I can move that person from the Medicaid to the ACA, I make more money that way. Mm-hmm. All right. But how much of that can you do, is really what it is. Because there's no, you can take share from somebody else, which is, I think, what Elevance is doing. Yeah. You can underprice your plans, which is what happened this year, to take share. But you're going to have it's not a very bright picture for
so then guys. This leads to the next story in modern healthcare. Insurers are inventing more roadblocks to claims, as reported by providers. This has been a fight forever, and it's always going to be a fight.
Yeah. And if you listen to some of the people staffing the health organizations, like Marty McCary, their response is good. Some of this stuff isn't valuable. Some of this healthcare is not valuable. It doesn't produce healthier patients. But the other thing that's at work here is that these guys mispriced their plans in 2024.
Yeah.
And they did that because they did not they're poorly anticipate. Well, let me rephrase this. They understand how competitive Medicare Advantage is. And there is some problems with the Medicaid disenrollment as well, but they are the Medicare Advantage is so competitive now, and the population is not growing. And they can't cut they can't increase their premiums because then they'll lose people.
Yeah, I agree with that. And this is the design of the U.S. healthcare system. Like, the payers are in place, in my view, to challenge, and hopefully it is an honest, healthy debate, but to challenge what the provider is delivering. And somehow it's messy, but that results in a reasonably efficient system.
That's your hope.
Of course, the insurers are putting up roadblocks. Mm-hmm. That, at some level, that's sort of their job.
Right.
They're not underwriting risk. I mean, they don't take risks more than 12 months. No. So there's no risk taking. They're not real insurance as far compared to life or fire or something.
Right.
They are adjudication and trying to limit. If that check wasn't there, then the providers would do more things. So that's their function, really.
It is their function, and the question is, are they doing it in a responsible, and intelligent way? And if you, listen to Andrew Whitty on the, 2024 earnings call, he is talking about the fact that they're in their very early stages of using, large computing models to help make decisions and have the evidence that they need in order to support those decisions. And
I did an AI show. I think it came out maybe 2 days ago. And we were talking about this arms race where both sides, the providers and the payers, it's in the early days, but they're both gearing up to use large technical systems, really mostly powered by AI. And they're going to be talking to each other. The AI systems are going to be
the battle of the machines.
Right.
And one of the things to remember about, health insurers is health insurers are basically actuaries. They're trying to figure out, all right, they're not basically, they are actuaries, right? How much am I going to spend this year based on all of these inputs, all right? And, that went from you had a slide rule and you had a ledger, and then that went to an Excel spreadsheet, and now its next generation as it goes into a large predictive model.
They're much better suited to quickly move into this than health systems.
Health systems, and health systems have to worry about the person in front of them, and more importantly, they got to worry about the doctor that was trained to do this many scans and this, and these those kinds of things.
Okay, last year, just quickly, Fierce Healthcare is saying in 2024, more nonprofit hospital credits were downgraded as opposed to upgraded, which is, I wanted to report, it's not that surprising.
Not at all, no.
There's a lot of pressure on health systems.
And particularly the nonprofits. I think that they do not have the cost controls, do not want to embrace the reality is you've got to run a more efficient system. And, here in Nashville, you go down from Vanderbilt and you go down the street to HCA, one of those knows how to run an efficient health system. Is it the Ford Motor plant from the 50s or no, it's not. But is it better than other health systems? I think it probably is. Yeah.
And then one of the factors related to this is that so the next story in Fierce Healthcare is hospital and private equity affiliated. So primary care groups that have an affiliation with a hospital or a PE firm have better network rates. Yeah. And that's because they leverage the broader negotiating power to get better rates.
Right.
The Nashville community, that's sort of one of the recipes in the Nashville recipe.
Yeah. What do you expect, right? If you're creating power in the insurers, which you did with the Affordable Care Act, right? What other response do you have if you're a health system? Well, you need to find that power yourself.
Especially something like primary care.
Which is one of the most important functions of the medical system and one of the most poorly paid. And so there's no. And then look at anesthesiologists and radiologists. Who goes in and asks for their anesthesiologist by name? Nobody. So it's a way to change the power structure. So nobody should be surprised. The people that created this, Congress, the passage of the Affordable Care Act, should not be wondering. It's their invention.
And these last two stories, the credit rating degrades and the fact that it's being researched and published that you can get better network pricing as a bigger group, is going to drive consolidation, right? I mean, consolidation is already happening, and we're going to see more and more of it.
Well, and it's going to drive consolidation in the way you drive consolidation as you're reaching the, kind of the end of a cycle, which we see all the time, right? You had this massive expansion of the healthcare system beginning in the 60s, but really accelerating beginning in 2014. And that system was built for the post-war generation. They conceived it. They incubated it, they expanded it.
And it's taken care of them.
And it has taken care of them beautifully. All right. But
as they
in 2027, the last of that generation will turn 65.
Yeah.
And from there, it's one big giant trough with a few hiccups until you get to the millennial population.
Yeah. And so we've had multiple challenging stories. And so I was looking for something that would lighten it up a little bit because it's just like bad. And so Medical Xpress.
See, I disagree. I think it's good.
Game-changing story that if you pair dogs with providers at hospitals, it eases both the staff and patients' stress and anxiety.
Of course.
Which, of course, we both are dog lovers. We both have dogs.
They're fluffy.
Dogs are great.
They're fluffy and they slobber all over you.
Yeah.
And
this was at an HCA facility, and they have dogs in the birthing center, and everyone loves the dogs. And they're part of the team. They come in 3 days a week and they cheer everybody up.
I think that is a really good use of HCA's money. So kudos.
I mean,
to
if you can keep one nurse a little bit longer, turnover is expensive. So
I'm all for that. And I think the American healthcare system, probably more than any other healthcare system, was modeled on military. Right? It was created and born out of a military system. That's why the Surgeon General is called the Surgeon General, right? And so it has this very uptightness about it, and like, not having a dog, disease, No, it's a perfectly healthy dog. And that's that leaving that behind, with the post-war generation is a really big positive, I think.
Yeah. Okay. So Johnson & Johnson got a new drug approved by the FDA. It is for major depressive disorder. It's a spray.
Mm-hmm.
It is on its way to being a blockbuster. It already had other indications. So it treats other types of depression.
Okay.
But this is the first standalone therapy for, treatment resistant, where you can't really get relief.
Yeah.
And so it's on its way to being a blockbuster, which is defined as $1 billion. J&J needs some new things.
They really do. Yeah.
And so they're celebrating this. It's not clear to me how effective it is, but it got approved.
This is going to be, back to that Wegovy model where we're paying a lot of money for a drug because we don't have good, processes and approval processes in our food supply.
Yeah.
I think the antidepressant and the anti-anxiety drug business is going to face a similar reckoning, which is they were spending a lot of money on these drugs. Almost everybody in America is on some sort of, mental health drug. So we need to look at why we're spending that money. Is it because everybody is the majority, literally the majority of Americans need antidepressants, or is there something else going on? In the case of the anti-obesity drugs, there's a belief that it's the food system, and the food supply. With the anti-obesity drugs, is it also the food supply? But Robert F. Kennedy is talking pretty openly about this. So I think you're going to see some medical attitudes change, which maybe J&J is not prepared for.
Well, I mean, changing the food supply it's hard for J&J to make money with that.
No, it's not. And that's
it'd be great if that could solve depression in any small way. We should do that.
Right.
But it's still not going to help J&J's business. They need to find.
Well, that's the big problem, right? Is a healthier population a good business model?
Well, it's good for the country,
right?
But
and I would argue
it naturally would shrink the healthcare system.
Well, and I would argue there's lots of things that we aren't doing, mostly in the private sector, that would make people healthier and not quack stuff, but make people understand how to take care of themselves better, which is underpenetrated. The market is underpenetrated for that.
Yeah. A.D.H.D. is a study in the United Kingdom.
Robert F. Kennedy, by the way, does not believe A.D.H.D. actually exists.
Oh, that's interesting.
Well, maybe that's hyperbole. It's not that it doesn't exist. Maybe it's overtreated. It's
overdiagnosed, I think.
Yeah.
I would say it's overdiagnosed. But a study of 30,000 British adults showed that people with ADHD are likely to die earlier than their peers. And so
I want to know what they
caught my attention.
I want to know what they control.
And we have the study here, so we'll link to this article. That makes me worried because I have family members with ADHD. But and then this is a cautionary tale. So a startup claimed that they could cure cancer by filtering the patient's blood. Of course, is not approved by the FDA.
I would think not.
And this is in the New York Times. There were two companies that sort of got together to work their way through the regulatory process. And they set up a treatment center in Antigua.
Which should be your first clue.
Which is your first clue. And 2 people have died. And so there's a lot of cancer patients that are interested in going outside the U.S. regulatory environment to find new therapies. And I think some of them have some promise, but this one killed people. And it's filtering your blood to cure cancer. I'm not sure that makes sense.
Yeah,
to me.
And putting your and the difference here, I suspect, is, or the important factor, my guess is that they were seeking cancer treatment at a cost they could afford, not necessarily seeking cancer treatment. And for all of this coverage information, we have, 93% of Americans are covered with some insurance. It's not particularly affordable, you know, and even on Medicare, you know, and not.
Yeah, there's a lot of CAR T treatments that are not covered.
They're not covered. Yeah. You can't get them, you know,
you can get them, but you have to be willing to pay.
Sell your house. Yeah. Right. And so that my guess is what is driving this more than anything else. But it's a terrible thing, you know, that something like that happens.
And then in our longevity sort of segment, there's a really good podcast. Marcus and I have decided we're going to try to, every few shows, recommend a podcast that we like besides this one. Of course, this is the one that people that are listening to this show listen to. But I would recommend Kevin MD. His podcast is very creatively called The Podcast. But he's talking about biomarkers that could boost your health span and longevity, which is sort of on the theme that you're saying that the government's turning to, is let's try to worry about health span and longevity and keeping people healthy.
Well, and being, while you're living your life, to be as healthy as possible.
Yeah, enjoy your life.
You know, I mean, I think the end-of-life care in the American healthcare system is one of the great scandals, right? You know, treating 85-year-olds for... we're so driven by the fee income and even the value-based care. It doesn't solve this problem, which is you really, there is a point at which your oncologist needs to tell you to go home. Yeah, you know, and have, you know, watch TV with your kids, and you know, and eat a few good meals, because
and there's so many social and kind of interpersonal family dynamics going on with that.
Yes.
That it's very difficult for the doctor to know how to broach that topic, how to talk about it, and who will make the decision.
Right. Yeah.
So it just doesn't get brought up.
They all need to talk to my mother, who kind of laid it all out, you know, fairly early on.
And just said, this is what we're going to do.
Well, the threat was she would haunt us if we deviated. And if you knew my mother, you would know to take that threat very seriously.
Yeah. So Innovacer, which we seem to talk about every week on this show, I think it was 2 weeks ago, they acquired another AI company. It's their third in a year. And this is AI for actuarial services. So Innovacers has built a pretty good suite of AI tools. They're here in Nashville, and they're definitely going with the broad, let's try to have several different AI tools for every use case.
Okay.
But pretty interesting. They're definitely building up a pretty good portfolio.
Yeah, that actuarial stuff could be really super interesting.
Yeah, especially when you pair it with some other tools that they have. Yeah. Okay, so I have an investment in a company that tracks that watches eye tracking to predict human performance, mostly for the military. So they're talking about like elite performance for pilots and other things. Mm-hmm. But this another research out of the UK, researchers found that they could use AI to predict dementia risk by tracking how the eye movements are moving, which is pretty interesting.
That is pretty interesting, and I think anything that helps you define that very difficult, you know, condition. There's so many. It seems like it's so multi-factor that
and dementia is pretty vague and broadly defined.
Yeah.
Versus something like Alzheimer's.
I mean, I had dementia this morning for a bit. So.
Okay, so now we're moving into the AI section. OpenAI announced that they have Ph.D. level super agents.
So they're stupid. Okay.
They're trying to use every buzzword they can. Agents are the new AI buzzword, and they have Ph.D. level super ones. And they're so powerful in this Axios story, it's reporting that they are having to brief the U.S. government before they release it. I don't have any inside information, but I'm very cynical about this. I think it is.
You deserve to be.
I think it's more hype than real, but we'll see.
Yeah.
I mean, I'm really interested in AI, but when Sam Altman tells me that he has to have a closed-door briefing with the U.S. government because his AI is so powerful, that sounds like marketing to me.
Yeah, it sounds like Sean Lane to me, too. I
don't know Sean Lane.
Oh, Sean Lane, his company Olive.
Okay.
This is so super secret. You know, we're going to get back to this problem that I mentioned earlier when we're talking about, you know, research, is that what you train your model on, if you want somebody to be PhD level smart, well, that ain't a high bar. right now. He makes it sound really, really like it's a big deal. Now, I'm not saying that there aren't some really smart PhDs out there who've done some really amazing work. There are, okay?
Yeah.
But you have to, if you're doing an AI, large language model, you have to collect as much as you possibly can, information, and research and so forth. And a lot of it's crap. And how
published research. There's many published research papers that have never been replicated.
More than half.
Yeah.
And in some fields, it's in the 60% range. Sociology, for example, education, because biomedicine or biomedical or biotech or whatever, because that has to go through a regulatory process.
Yeah, we're better. It's better.
It's
more
better,
quality. Yeah.
but it still can be pretty junky as well. And that's where you get the Alzheimer's situation.
Yeah. Yeah, so we'll see. February 1st.
I'm with you. And look, they put Mike Allen and Jim Vanderhei on that the story, the two founders of Axios.
Yes. China is evolving into our biggest geopolitical competitor to the U.S., and they released a new AI model that they built with very inexpensive chips. I think primarily to say, thumb their nose at us, like we can't get the NVIDIA chips, but we don't need them.
Right, yeah,
anymore.
I'm sure that is true.
I tested this model. It is okay. It's not as good as the U.S. models, but it was built with like 5% of the money. So that, like, it's not quite as good, but it is still important to track, if they are able to make it better over time.
Yeah. Well, I mean, I think when you start talking about AI, the ability to take a bunch of information, whether that's, biomedical research or whatever, take a bunch of information and turn it into something usable. All right. Yeah. I think there's going to be, and I think there already is, a tendency to think about the prospects of that as, well, I need to essentially create the, nuclear, armament of intellectual pursuits. And you don't really. You really need that thing that's usable for that particular task.
Yeah, right.
And a cheaper chip would be nice, because everything doesn't have to go at light speed. Everything doesn't have to digest, the entire research library at NIH. Let's just get.
Yeah. I mean, I don't necessarily, in order to help me edit my blog post, I don't know if I need a Ph.D. in English literature studies.
No.
Like, I need someone to correct my grammar, or I need a thing to correct my grammar, and then, punch it up a little bit, like you'd say in speech writing, to make it a little bit more interesting. It probably is like a middle school teacher.
Yeah. I've got the Associated Press edits all my stuff, and I very frequently ignore them for what it's worth.
Interesting. Yeah. Okay. So the last story is going to go exactly to what you just were talking about. So AI has passed so far every test that humans can create. We ran into this problem where there was no way to test how the models were doing compared to each other, because they all were getting 100 on every test.
Right.
And partially we have an issue that after the test has been out for a little while, the answers are no.
Yeah.
And so it either is the AI is very smart, or the answers are embedded in the training algorithms. But people a group of humans made a new test called Humanity's Last Exam that they think is the hardest test that humans can create. And so I'm going to read this so we can try our hand at this. Hummingbirds within the adder performs uniquely have bilaterally paired oval bone, a seismon embedded in the caterolateral portion of the expanded cruciate. How do you say the next word?
Aponeurosis.
Of insertion of the M depressor cold. How many paired tendons are supported by this sesamoid bone?
Sesamoid bone. 64.
That's amazingly. That's correct. I have no idea what that is. But
are the answers at the bottom?
No, they don't have the answers.
Oh, okay.
These people have the answers, but they're not giving them away because they want AI to be able to answer them.
Okay.
And so it is just interesting that we are, I don't know if we have AGI, meaning AI that is smarter than any human, but we are getting to the point where humans don't have the ability to test AIs anymore.
Oh, yeah, they could tell us anything, right? And we'll
Yeah,
buy
you can answer that question with any number between 1 and 1,000.
Yeah, as long as it's not bigger than a hummingbird, right?
Yeah, right. Well, I don't know how small the bones are.
Yeah, I don't even. I mean, a hummingbird. Those are really little animals.
Yes, but they probably have little bones.
Little bones. But the one of the things that runs through a lot of these AI stories, I think, and this goes to Barack Obama's interest in it, I think, and that is that AI is trying to be painted as this existential threat to humanity. And Elon Musk has even said this.
Yeah.
And of course that assumes that there will be no effort to countermand that existential threat,
or that we won't be able to.
Yeah, humans are very good at self-preservation. Mm-hmm. We've been at it for a while, so I'm not particularly worried about that. But the theme that runs through this is kind of like a doomsday, kind of thing.
I mean, PDoom is what's the probability that the human species will be extinct? I mean, people put a prediction on it.
Right. And this is kind of, we've seen this so many times through human history. And really what it is just an expression of the anxiety of our times, right? Yeah. Which is, get off Twitter, don't go for a walk in the park without your,
without
Spotify,
your
without your phone. And go find somebody you can help, have a better day. Yeah. But the that is really what it's expressing to me. And the fact of the matter is AI is going to be very helpful in getting work done that you need done and writing code and creating apps and doing all these things. AI is so far, for me, not been particularly helpful. And I don't know if that's because I spent a lot of time in working with humans, coming in contact with each other and making power decisions.
So when a 800-page bill is dropped, you don't use AI to help you sift through it. You've read enough of these that you can.
I don't really need it to, because I've read enough of these as well. But when I do, I used AI the other day. So when I've got the executive orders, okay, and one of the executive orders 14009. And so I asked my Grok, which is the only AI I've got access to, all right, which federal rules published in the Federal Register relied on Executive Order 14009? And it gave me a list of, I think, 3, okay? There are actually more than 3, but they did get the big ones. Okay. So in that sense so that
saved you time.
Saved me time, yes. And I would say probably a decent amount of time, because to find that answer otherwise would have been, a search of the Federal Register, which doesn't have a great search engine, which is probably a better answer, in the long run. But, if I ask it something like, please tell me, what Donald Trump's express priorities through his executive orders are, what are those, that body of information tell you? It's crap. It can't really, it doesn't know how to calculate or express human ambition, vengeance, anger, and also, I think, a genuine interest in fixing some very broken things.
Yeah. Well, I think I disagree somewhat. I think for my use cases, it's pretty good quality. It's the quality of a. If I hired a college intern, so I'm typically looking at a new business to invest in, or I'm doing something, doing a lot of market analysis, like what is the existing status quo in this niche space,
right? And
who are the competitors, and what is the relative strengths of SWOT analysis, maybe for it. And I could hire a college student for $15 an hour to do that. and they do a pretty good job.
Right.
It's not like I can't just like put it into the investment memo, but it saves me a lot of time.
Yeah.
And I used to do that. And I've used almost every of the AI tools. They're all different strengths and weaknesses, but they all are pretty good at replacing that, average to medium high IQ level, but really not an expert at that competitive market.
Yeah.
And it happens in something like 15 seconds as opposed to a week.
Yeah.
And it cost me $20 a month.
Yeah.
So, but the problem I have is that I really don't have a good interface, right? So it doesn't then fit into my investment memo. It doesn't help me with emails. Like it doesn't connect to my life. I have to then copy it out of that program and then put it into a Word document or a Google document. And so I find it to be pretty useful, but the interface points are still, the UI is terrible, and I'm literally cutting and pasting on the clipboard in a way that is not ideal.
Right. Yeah.
And so I think we're still in the early days. And
somebody's going to make a lot of money by thinking without AI. Think about that. Eventually, everybody will use AI, and then
then there'll be a new thought.
Then there'll be that new thought.
Yeah. Yes. That's right.
That'll be me, because I'm not a Luddite. I'm not that bad, but I also
you're designing a new app for HHS.
I know.
You're not a Luddite, but you are. You want it to be a certain level of quality, and you also know some of the inputs aren't that good.
Yeah, and what you know about AI or any tool really is, back in the day, you still have, you got a carpenter. He's got a hammer and he's got nails. AI is hammer and nails. They're not going to be the carpenter. No matter what the doomsday expression is. The carpenter will adjust as time goes on. And
I think that's right. Human creativity and human empathy are
what makes us human.
Yes, that's right. That's right. Okay, well, thanks for hosting. It was great to have you. We will have Marcus back next week.
Yeah, he's going to have to edit this, right?
No. I'll get it out on Saturday.
Oh, okay.
Yeah.
All right. Well, I'm looking forward to it.
We have an editor.
Editor. Actual editor.
Yes, a real editor.
All right. Well, I enjoyed it. Thanks for having me.
Okay.